Welcome, everyone. We're just going to give a few folks a few more minutes before we start the presentation. For everyone that's joined us so far, we're just going to give folks one more minute to come on to the Zoom, and then we will begin the presentation. Welcome, everyone. I'm Kimberly Shahan, Regional Resource Director for Caron Treatment Centers here in Florida. Welcome from Caron Renaissance today. Thank you for joining us on today's webinar on the topic, Treating Trauma and PTSD in Older Adults, Uncovering and Healing a Lifetime of Experiences. Thank you for, as a reminder, we'll be conducting this session in a webinar format, meaning all participant microphones will be muted. We will not be able to see or hear you. During the presentation, please utilize the chat and the question and answer features so that we can communicate with you that way. Depending on the volume of questions, if we can't get to your question before the end of the hour, we will have someone from our team follow up with you directly. Today's presentation is eligible for 1 continuing education credit. We would like to thank our educational partner, CE Learning Systems, for assisting in providing these credits through co-sponsorship with the American Psychological Association. Please note that in order to receive your credits, you will need to complete the post-webinar evaluation. A link will be emailed to you directly after the presentation from cego.com. After finishing the evaluation, you will have immediate access to your certificate of completion. Today, I am proud to introduce our presenter, Diana DiGirolamo. Diana is a behavioral health therapist in the older adult program who provides individual, group, and family therapy, as well as psychoeducational groups, lectures, and aftercare planning. She is a member of Caron's trauma team and is trained in cognitive processing therapy, CPT. Since joining Caron in 2013, Diana has worked as a therapist in our women's, men's, and relapse programs. Her compassion, knowledge of different therapeutic styles, and ability to challenge patients and families is the foundation of her work. Please welcome Diana.
Thank you, everybody. I'm Diana DiGirolamo. I'm a behavioral health therapist on our older adult program. I'm glad to see so many people have registered for this topic. I have been doing a lot of research in this area, and I also have quite a bit of experience in working with our older adults. We opened the older adult program in 2015, and we built this new building in 2017. So I've been with the older adults since 2015, and I've really enjoyed working with them. It's interesting because, you know, a lot of times I've heard people say, well, it happened so long ago, but I'm here to tell you, and the evidence will show you that the impact of trauma is definitely still present in older adults. It doesn't just go away. The symptoms don't just go away. So to start, I just have a few operational definitions for the purpose of the presentation. So the way I'm defining trauma is a deeply distressing or disturbing experience, physical injury. It can also be emotional or spiritual in nature. The different types of trauma, acute trauma is usually what results from a single traumatic incident. There's chronic trauma, which is typically a repeated or prolonged exposure. This can be childhood abuse, it can be sexual abuse, it can be domestic violence, but it's over a prolonged period of time. And complex trauma, which I see a lot of in my work with the older adults, is several different traumatic events that occur in one's lifetime. So this could be chronic trauma, including several different incidences of acute trauma. It could be a car accident, and then, the loss of a spouse, and then physical abuse. So it can be a bunch of different traumas that happen over time. And post-traumatic stress disorder is a specific diagnosis in the DSM-5. It's a mental health diagnosis, and there are certain criteria that have to be met in order to meet criteria for a post-traumatic stress disorder. We treat, in our trauma program, we treat both people with post-traumatic stress disorder diagnosis, as well as people who have just experienced trauma and may not necessarily meet criteria for post-traumatic stress disorder, but nevertheless are experiencing some symptoms of the trauma. And the definition that I'm using for older adult, just for the purpose of this presentation, is the chronological age of 60 or over. What I will tell you is that we have treated individuals on our older adult program from ages 31 to 91. Sometimes people come on this unit and they have medical issues, or they're cognitively compromised, and they need 24-hour medical care. So there have been some younger folks that have been on the unit at times. So the scope of the problem. In doing my research, I was looking at, how many older adults struggle with post-traumatic stress disorder or just trauma in general. And the research was indicating that adults over 60, about 1.5 to 4% have post-traumatic stress disorder. A lifetime prevalence of PTSD in the general adult population, so that's including under 60, 18 and over, is about 8%. And about 2 to 17% of US military samples. So that's a very large variance there. So I have some other numbers to go off of. So even if an individual, an older adult 60 or over, does not meet full criteria for post-traumatic stress disorder, like I said before, they still can exhibit trauma symptoms. And I'll talk a little bit more further in the presentation about some of the instruments that we use to assess that. So there is about, and these are according to the American Journal of Geriatric Psychiatry, where these numbers have come from. So about 7 to 15% of older adults do meet subclinical levels of post-traumatic stress disorder. So they don't necessarily meet the diagnostic criteria for PTSD, but nevertheless are having some of the symptoms. 90% of older adults have experienced at least one traumatic event in their lifetime. Also, post-traumatic stress disorder in general, it ranges from about 2.8 to 4.5% of the population. Now that's from the Department of Veteran Affairs. I did get some of my information from them. It was very helpful. But the lifetime rates of PTSD in older adults are estimated at about 4 to 4.5%. So before I get into any of the treatments or anything like that, I do want to talk a little bit about barriers. Post-traumatic stress disorder seems to be very under-recognized and undertreated in older adults. Again, when I was looking for my research, it was very hard to find a whole lot of information that was relevant and specific to older adults in trauma and not outdated. So I was really doing a lot of digging to find some more relevant and recent data about this. So that tells me if there's not a whole lot of research and information, I think that there's more research that needs to be done. So assessment and treatment, it can be challenging in this population. There's a couple different reasons why. There's sometimes cognitive deficits or sensory decline. There's also comorbid mental and physical disorders, as well as substance abuse. So I work on our older adult program, and most of the people that come in have an alcohol use disorder or another substance use disorder. So there are other co-occurring issues that we're dealing with as well that could complicate their cognitive function and their physical function as well. There is less research on trauma and PTSD in older populations. That's what I had found, as opposed to younger or middle-aged adults and children. There's a lot more information for children with trauma than there was for older adults. Absolutely. The thing that we found and that the research also supports is that older adults tend to not necessarily recognize or admit that there are trauma-related difficulties. Some of the issues are that they will often report somatic concerns, insomnia, GI issues, heart issues. There's definitely a stigma attached to trauma with the older adults. The boomers, I found, are a little bit more open about it than the older adults that we treat. But there's definitely some reluctance in experiencing. A lot of times I'll hear them say, oh, but that happened so long ago. But then they'll score on an instrument that we give them, they'll score high in terms of trauma symptoms. So it's hard to, you can't just go off of what they're reporting, but also what are the numbers saying. So one of the things that's very important, as I said, is assessment and screening. So this needs to be something that's done routinely. When a patient comes into Karen, we do assess them pretty extensively from a medical standpoint, a psychological standpoint, a clinical standpoint. So we're looking at several different things. So older adults typically, like I said before, don't report traumatic experiences necessarily. They tend to minimize the importance of these situations in their lives, especially if it occurred a long time ago. They also tend to talk about problems and respond to questions a little bit differently. Sometimes I'll hear them ask me like, why are you asking me these questions? You know, how is this important or relevant to my treatment? I'm here for alcohol or depression or anxiety. So like I said before, again, they'll report a lot of physical concerns. The other thing I notice them report a lot is depression and anxiety. A lot of them, majority of my patients will report depression and anxiety. And a lot of that comes with social isolation, strained relationships. There's other factors that are involved in that. So typically what will happen is rather than an older adult seeking out a therapist or a helping professional, they will seek out their primary care doctor. And they will report physical complaints. Like I said before, you know, heart issues, GI issues, insomnia is a big one. We see it a lot here, insomnia and GI issues a lot. So they'll do that, but they won't seek out the mental health services. Typically, it's important to note with older adults, asking them about any kind of changes in their mood or their level of activity. There can be a lot of different factors, their level of interest in things that they used to do. You know, a lot of these older adults, they're facing many changes. And for them, you know, it could be a change. They might have retired. They might have lost a spouse. They are maybe experiencing limited mobility and not able to do some of the activities they used to do. And they feel as though quality and purpose of life is missing. So that's important to assess and look into further. And the good news, though, is many of the instruments that are used to measure PTSD have been valid in terms of measurements with older adults. So what specific measures are good to use for post-traumatic stress disorder, and also what we use here at Karen to assess for appropriateness of different trauma services that we provide? So one of them is called the CAPS, Clinician Administered PTSD Scale. I got this information from the National Center for Post-Traumatic Stress Disorder. The CAPS is it's a questionnaire. It's 30 items. It's a structured interview tool. And the questions are corresponding to the DSM-5 diagnosis for post-traumatic stress disorder. The PTSD checklist, or PCL5, which we use here at Karen, is a 20-item questionnaire. It's a Likert scale, and it ranges from the answers range from not at all to extremely. So they're asked 20 questions, and there's a clinical range that they have to meet in order to qualify for a diagnosis of post-traumatic stress disorder. And those who do have a high score, clinical score, will be referred for trauma services. Now, I'll get into that more about what specific services are appropriate, but typically if it meets a clinical range on the PTSD checklist, we would like to get them engaged in something called cognitive processing therapy, which I'll talk a little bit further about in the presentation later on. The primary care post-traumatic stress disorder screen is something that's typically, we like to see it implemented in primary care docs, because like I said before, a lot of these older adults are going to their primary care physicians and reporting these symptoms. So if we're not screening, we're going to think it's something that is somatic and treat them for insomnia or treat them for GI issues, when maybe that just might be the symptom of something else going on. So the primary care PTSD screen is a 5-item yes or no questionnaire. Now, if the patient says no to all 5, then there's no further intervention there. The other thing that's important to note is suicide assessments. Suicide assessments are really important in older adults. One of the things that's been found, according to the National Center for Post-Traumatic Stress Disorder, is that older veterans are definitely at higher risk of a completed suicide than middle-aged veterans, which I found to be interesting. So there were a couple of studies I looked at, a couple things from the Journal of Geriatric Psychiatry and the Journal of Alzheimer's and Dementia. In the Journal of Alzheimer's and Dementia, there was a study on risk factors for and the consequences of post-traumatic stress in older adults that were evaluated in the emergency department following a motor vehicle collision. PTSD was a risk factor for dementia in both sexes, they found, with a heightened risk in those with a comorbid depression. Another study in the American Journal of Geriatric Psychiatry noted that PTSD, there's evidence that PTSD is associated with premature aging, which senescence is the formal word for it, but it's accelerated aging, and could have major implications for quality of life and healthcare policy. These are things, again, that I think warrant a lot more investigation. There was a study conducted on a comprehensive review of the published empirical studies relevant to the early aging and associated with post-traumatic stress disorder. And the evidence suggests that post-traumatic stress disorder may be associated with accelerated aging. But again, further research needs to happen. So another study, which was from the American Journal of Geriatric Psychiatry, indicated that older adults with chronic PTSD are 3 times more likely to have a disability, which I found very sad. Self-care problems, mobility issues. A lot of our folks that come into treatment ambulate with a walker or a cane. They have some kind of physical difficulty in ambulation. And cognition, which is significant, and that will come up again further in this presentation. And I'll talk a little bit about how we screen for that. So they were 3 times more likely to have one of these disabilities than those who did not meet criteria for a post-traumatic stress disorder. So being opposed to a traumatic event, the literature seems to show it is associated with adverse physical health consequences. So that could be self-reported, like the insomnia, the GI issues, that kind of thing, pain, to actually diagnosable conditions. Chronic pain and PTSD tend to co-occur. That's another thing that we do treat here, is we have a chronic pain program for our folks, which includes massage, acupuncture, sometimes biowave, also hydrotherapy, and a chronic pain support group that's offered to help people manage their pain more effectively to improve their quality of life. So again, things like trauma, if they are definitely leading to adverse physical health consequences, they're going to exacerbate already existing conditions as well. Older veterans. So I have treated quite a few Vietnam veterans here on the unit. And obviously, it's a high rate of exposure to traumatic events. Male veterans, the prevalence of lifetime exposure to traumatic events is about 85%. It's quite high. PTSD is reported to be more prevalent, though, among younger veterans. And I think the next bullet point kind of explains that a little bit more. Older veterans tend to report more somatic complaints. This kind of goes back to what I've been saying before: appetite, sleep, memory problems. They also report less depression, hostility, and guilt than younger veterans. And I think too, some of that goes with the stigma. I think we've talked a lot more about mental health. The younger generation has been more exposed to the idea of talking about your feelings and things like that, whereas the older folks, they come from a generation of, you deal with it and you move on. So there's been a couple longitudinal investigations with samples for veterans regarding traumatic exposure and the effects on health and functioning. So there is a significant association between PTSD and dementia, as well as the senescence, the accelerated aging that I was referring to in later life. This is indicative for PTSD that older adults are at risk of not receiving timely and appropriate mental health treatment. So what I see a lot of times, and what the research has shown, and in the next bullet point, we'll talk about this a little bit more, but we do screen all of our older adults when they come in. We give them a cognitive screen. It's called the Montreal Cognitive Assessment. Now, this is just a screening tool. This is not something that provides us with a whole lot of baseline data or percentiles. So we measure things like short-term memory, delayed recall, attention, verbal fluency, visual spatial skills, and executive function. So we're just kind of assessing where they're at with that. And we do find that most of our older adults score below the normal range. So it's scored out of 30, and a 26 to 30 is within normal range. Most of our patients score below that. What we see is some time away from the alcohol, some time in therapy. Usually that score goes up. So that's pretty indicative of what the substances have done over time. So there was a sample that over 180,000 veterans, those with PTSD, were more than twice as likely to develop dementia over a 6-year follow-up. Again, I found this quite sad. Again, early intervention is really important, and there does need to be some kind of targeted outreach for this population. The other thing that I find difficult for older adults to do is to navigate the system with their insurance, with what services are available, and I've dealt with this with just trying to help older adults that I know in my personal life, and trying to contact the Office of Aging, and trying to contact, Easter Seals or different volunteer and nonprofit organizations to get services in place for an older adult. And it can be very, very challenging. And a lot of the adult children of these folks end up having to step in and take care of it for them. In a sample of over 10,000 veterans age 65 and older, those with PTSD had almost twice the likelihood of developing dementia compared to those without it. So those are just two samples that found the same information about PTSD and dementia. So COVID-19, this has been an interesting time period. I did want to add just a little bit about this. It was interesting because I really couldn't find any research about older adults specific to PTSD and COVID-19. It was just COVID-19 and trauma, or COVID-19 and PTSD. So over the decades, there have been findings that have indicated that infectious disease epidemics can be a very traumatic experience for some people. And those of us who, we've all been through this pandemic and have experienced many different issues as a result of it. It can cause PTSD. It can lead to chronic psychological distress. So again, there's a lot more research that still, I think, has to be done long-term of the ramifications of this pandemic and all of the aftermath that's been occurring. But some of the emerging literature and based on previous studies of infectious disease does provide some insights into a risk factor that correlates with post-traumatic stress disorder. If you look at some of the consequences that could have occurred from COVID-19. People may have had loved ones that passed away. They couldn't be there to support them in the hospital when they were sick. The loss of employment, the financial insecurity. There had also been research that indicated that there was an increase in domestic violence and child abuse during this time. And many of things were closed or operating only at a minimal capacity, and people were not getting the services they need. If you are a therapist out there, I bet you're probably booked or close to booked with all of the people that are reaching out for services. I found it very difficult to find services for my folks when they're discharging from treatment. I have found that another barrier is Medicare. I found that there are less providers that are in network with Medicare. You know, our folks, they come in and they pay for treatment, and then they want to use their insurance for their aftercare. And it can be very challenging to find providers that are in network with Medicare that do all the services, especially the trauma piece that we're looking for. So that's a little bit more labor intensive to find that. But we must really find that for somebody who is in treatment and has trauma. It's very important. So I went over some of these in the previous slide, but there was an indicator that being hospitalized for COVID-19 could be a significant risk factor for post-traumatic stress disorder or chronic psychological dysfunction. I think, again, it goes to, you know, those who might have been hospitalized, they couldn't have family visit, the fear that came with it, of all of the possibilities, of how serious it is. Also pre-existing chronic medical conditions or treatment-related complications that could have occurred for people, you know, who were hospitalized. That lack of social support, the guilt that people carried, I think of their fear of infecting others. I know, and I'm a young person who's not immunocompromised, but one of my biggest fears working with my older adult population was I had this overwhelming fear that no matter what precautions I took, mask wearing, cleaning, everything, that I was going to pass this on to one of my patients. And that to me was absolutely stressful and a little traumatic. So I'm really grateful that I was able to get vaccinated to keep, you know, my unit safe and, you know, not have so much fear. I mean, I was under constant fear of hurting, you know, the patients by having this. So, so I'm glad that we were able to get vaccinated on the unit here and most of the staff here. So symptoms of post-traumatic stress disorder can increase with age. This kind of goes back to what I said, that, you know, it doesn't just go away. You know, role changes can be a definite trigger for some of the symptoms to come out. One of the things that I've seen with our older adults is the COVID-19 really socially isolated them, and then they were drinking really heavily, and you know, it was like their families were intervening later because they didn't realize the severity of what was going on with their loved one, because they couldn't even see them or visit them with what was going on with COVID-19. So it definitely, you know, I've had patients talk about incidences that have happened when they were 5, 6, 7, and they're in their 70s or 80s, and they remember it, and their trauma symptoms are clinically significant to meet criteria for a post-traumatic stress disorder, which is indicating that they are experiencing symptoms as we speak, 60, 70 years later. So some of the stressors that we see, you know, retirement, health issues, loss of mobility, decreased sensory abilities. One of the common things we see here on the unit is difficulty hearing. Some of our folks have hearing aids, and then their hearing aids don't work, or they lose a hearing aid. Loss of loved ones. A lot of people with a loss of a spouse, their children have moved out of the house. They feel not as productive, and cognitive impairment, which we see a lot of. So adaptation and resilience develop over a lifetime. And I've seen some folks who, although they do meet criteria for post-traumatic stress disorder, they are quite resilient in what they've been able to accomplish. However, it's still indicating, though, that the symptoms of the trauma are active. So their quality of life becomes impaired. Again, like I said before, I won't repeat this about the reporting more physical symptoms. Definitely, they do report more hyperarousal than younger adults, which I thought was interesting. Older adults, too, are typically less likely to identify their problems from a psychological framework. it's just a lot of times overlooked in their eyes. So, and again, I think that comes down to the stigma. So older women, there is not a whole lot of research with the effects of older women. They have been underrepresented in a lot of these studies. But for women in general, there's been more research about the effects of rape, domestic violence, things like that. I thought it was interesting that 72% of older women reported that they experienced at least one type of interpersonal trauma during their lives, whether that was childhood abuse, sexual abuse, rape, etc. 44 to 55% of women all ages reported having experienced some kind of lifetime interpersonal trauma. And intimate partner violence, this was interesting. It's especially relevant in older women. Now, if you look at the differences, before, women were getting married younger, and typically, you didn't see divorce often, in the 40s and 50s and 60s. Typically the women were more likely to stay in the relationship long term. So PTSD and co-occurring disorders, which we see here. So we see a lot of co-occurring disorders. They come in for a primary substance use disorder, but oftentimes more than half of, we have a capacity to have 15 older adults on the unit at a time. And there have been several times where more than half of our population on this unit has been in some form of trauma programming. So it's definitely something that is important in this population, and we see a lot of more often than not. So there's physical conditions, limited mobility. There is health issues, hypertension, hypercholesterolemia, hyperlipidemia, neuropathy, unsteady gait. These people have walkers and canes and wheelchairs, and it's cool to see them come to life and start ambulating well again. They also have mental health issues, depression, anxiety, trauma history, and cognitive issues, which complicates the matter a little bit. So with the cognitive issues, like I said, we do the screening tool, and we tend to, if somebody scores below normal range, below a 26 out of 30, we will retest them further on in the treatment process to see if that's cognition has come back. Because if it has not, that's indicative of a dementia or Alzheimer's, something organic going on there. There's also alcoholic dementia, which we have seen on this unit. We have had patients come in who are diagnosed with alcoholic dementia. We've also seen patients who are misdiagnosed with alcoholic dementia because when they took the cognitive screens outside of here, they scored low. And then after a couple of weeks away from the booze or the drugs, their score went back up. So sometimes people are not diagnosed correctly if they're not getting the right services or identifying the problem correctly. So with somebody on the unit, if they do have cognitive cognitive issues, what we'll do typically is kind of alter the treatment. So especially if it's something with delayed recall or short-term memory, they're not going to be able to retain the information as well. So it's really important to write things down. It's important to provide handouts for people. And, what I typically will do is, they will just be doing kind of the minimum trauma work where they would do the psychoed groups, but maybe not the EMDR or the cognitive processing therapy or something more manualized going forward. Let me see if I missed any information on here. We see a lot of people with diabetes and skin problems. We see a lot of people, they haven't taken care of themselves. They haven't gone to the doctor, dental issues, things like that too. So what do we do? How do we treat this? It's important to assess appropriately. And, when they're here for addiction, it's hard to decipher what's what in the beginning. That's why ongoing assessment's really important throughout the course of treatment. We're fortunate because we are a 6-week treatment program. So we have our folks for a little bit longer, but it is typically found, the National Center for Post-Traumatic Stress Disorder indicates that both medications and various types of trauma-focused psychotherapies, manual therapies, manualized ones are very helpful for this population. Patients with comorbid depression also benefit from the combination of using some kind of antidepressant medications along with psychotherapy. So what are some of the effective therapies? Well, there's a lot of them. There's exposure therapy. This is a technique of behavioral therapy that's used for anxiety disorders. It can be used sometimes for people with obsessive compulsive disorder or trauma that involves exposing the patient to the source of the anxiety. So if it's like spiders, exposing them, as long as it's not dangerous. If somebody's afraid of heights, you obviously don't want to have them jump off a building. That's, but you use, things that are safe and ethical to help them overcome their anxiety and their distress, and you continue to expose them to those events. Cognitive processing therapy. This is an intervention that several of our staff here are trained in and provide, from behavioral health therapists to psychologists that are here. This is a manualized therapy to help those who actually meet criteria for a diagnosis of post-traumatic stress disorder. It also, there has to be an event, a specific index event, and that they do the intervention around. This is a 12-session process, and typically what happens if you have patients here for 6 weeks and you do it about 2 to 3 times a week, we have seen people score from the PCL, the checklist, from like a 55 to a single digit, like an 8, which is pretty impressive to see that in this period of time from this intervention, this short, brief intervention, that their symptomology has gone down significantly. So it works. And I hear from a lot of the clinicians here how excited they are when they see that, when they test them, pre-test and post-test for symptomology. EMDR is another service that some of our behavioral health therapists and psychologists provide here for people if they're deemed to be appropriate for it. This was developed by Francine Shapiro in the 90s. The person is asked to recall the distressing image, and then the therapist directs the patient in some type of bilateral sensory input, such as side-to-side eye movements. And a lot of you guys are probably trained in that, so you understand what that is. But that is another service that we provide, if appropriate, for patients at Cairn. CBT, cognitive behavioral therapy, is really important as well. That is something that's offered, the psychologists do, for people who have anxiety or depression, to help them to challenge some of the cognitive distortions that they might have. There could be cognitive distortions around the trauma, and improving their emotional regulation. Coping skills are very important to learn and to practice while in a safe setting, not to wait until you leave. It's important to start them now. Something that's interesting, another therapy is called life review therapy. I found this from the Department of Veterans Affairs, and it's also known as reminiscence therapy. Now, what I'll tell you about this population in older adults is they really like to tell their story. You can't go into a session with an older adult with an agenda. It doesn't work. You have to listen, and they really appreciate when you just take the time to listen to them tell their story. You will get so much information from them based on what they go into about their life. And it's a great way to continue to ongoingly assess. And more information will come out over time, just like with any patient. But one of the things that's very valuable for them is to be able to tell their story and have somebody sit there and listen to them. Narrative exposure therapy is a treatment that's for, trauma spectrum disorders, and it's survivors of complex trauma, so multiple traumas over time. And the theory is that there's a dual representation of traumatic memories. Treatment for trauma disorders, particularly in individuals with complex trauma, it's been found to be effectively used in community settings and with people who have experienced trauma as a result of some kind of political or cultural forces, such as refugees, things like that. Couple more. Brief eclectic psychotherapy is an approach that combines elements of CBT with the psychodynamic approach, focuses on changing the emotions of shame and guilt. A lot of times people with trauma blame themselves. They have distorted thought distortions around what happened to them. And it really emphasizes the alliance between the patient and the therapist. Trust is really important. If you're doing trauma work, trust is a very important element to the work that you're doing with the patient population. Prolonged exposure, which I'm sure many of you are familiar with, it's a form of behavioral therapy and cognitive behavioral therapy that is treating post-traumatic stress disorder, typically by imaginal and in vivo exposures. It's repeated on purpose, retelling of the trauma memory. And then there is, a combination of psychoeducation, relaxation training, development of coping skills, and cognitive behavioral therapies together are all recommended. An experimental approach, which I really don't know a whole lot about, but I did read in the American Journal of Geriatric Psychiatry that there is an experimental approach for MDMA assisted psychotherapy. It's called MAPS, Multidisciplinary Association for Psychedelic Studies. It's a nonprofit research and educational institute, which did get FDA approval for the use of MDMA. We do not do that. We're also we're a drug and alcohol facility. So we don't use marijuana, we don't use MDMA, we don't use any of those to treat trauma. So there are a couple different types of medications: SSRIs, SNRIs, tricyclic antidepressants, alpha blockers, and atypical antipsychotics that can be used for treatment. You got to look at the other co-occurring issues. If there's a co-occurring depression, if there is a bipolar disorder, you're going to use different pharmacological interventions. And our psychiatrists and physicians here work together with our psychologists to assess, if a medication intervention is appropriate and what that would look like. So some of the common ones are Zoloft, Paxil, those are SSRIs. Also Prozac and Effexor, an SNRI, is used as well. Imipramine has been used as a tricyclic antidepressant, and Prozicin, alpha blocker. So this is also good for lowering blood pressure, which helps with anxiety. I'm probably pronouncing it wrong. Prozicin is also, it helps with nightmares. I've had some patients who tend to have nightmares as a result of trauma. It's one of their trauma responses, and we've used that before, and it's helped. And then sometimes people are treated with Seroquel for, if they have a bipolar disorder in conjunction, mania or depression. The problem is with older adults, you have to be really cautious about medications. You got to look at interactions with other medications that these folks are taking. They come in with a long list of medical issues, and you got to be cautious. Like our doctor, he does such a good job of ruling out, based on these patients are on blood thinners, these patients are on heart medication, some serious medications. Older adults can be more sensitive to the side effects. The other thing that I find is I get a lot of patients who have been treated for trauma with benzodiazepines, and they've become dependent on them. And benzodiazepine withdrawal is one of the worst withdrawals, especially for older adults. It takes months for them to safely get off these medications, to resume any level of sleep. It affects their memory. It makes them extremely anxious as they're coming off these medications. So we've had folks that have come in just to get off the benzodiazepines. It's a long process. Also, marijuana is not recommended. It can really exacerbate psychiatric illnesses. However, 28 states and DC have now legislation that is allowing for the use of cannabis for PTSD. We do not subscribe to that. What are we doing at Karen? So there's a couple different things. We have our trauma programming, which again, all of these on this slide are part of that. The trauma group is a 4-week rotation. It's a psychoeducational group, and these are gender specific. And actually with the older adults since the pandemic, it's been specific to this unit because we really had to keep we kept all the units separate, but as things are getting back to normal, we still are keeping our older adults separate. So the topics for those are: what is safety, what is PTSD, trauma in relationships, and trauma in the brain, how it affects the brain. EMDR is a service that's offered here. Typically that'll be run by a clinician 1 to 2 times a week. Cognitive processing therapy, this is a 12-session intervention that's usually done 2 to 3 times a week, but it's not done unless somebody's going to be able to stay for the full round of treatment. It's not ethical to start something like this if you can't finish it here. Trauma sensitive yoga is offered once a week. That is also gender specific. And we also implemented a family trauma program recently in the last couple of months, just to educate families about the trauma and the impact on their loved one and the family. Cognitive behavioral therapy is offered by our psychology staff. We have CBT groups that run weekly. And then there's also psychological follow-up where many of the therapeutic approaches can be used. Medication management, if appropriate and determined by the physician and the psychiatrist. And aftercare planning. This is an important piece. We have to make sure that we have services in place for ongoing trauma work for patients who have started that at Cairn. So overall, that's all I have. But I am definitely open to any questions that you guys might have.
Thank you, Diana, so much for your presentation. And we're now going to answer some of the questions that were submitted through the registration process. So the first one of those questions is, does trauma alter one's brain?
Yes, one of the psychoeducational groups that I run is on trauma and the brain specifically, because yes, it absolutely does. So typically in a normal brain, the thalamus is responsible for sensory information, what you see, what you hear, what you smell, taste, touch. And then the hippocampus, your memory storage, it comes to the forefront, and the amygdala is what determines whether it's a safe or an unsafe situation. And in a normal brain, the prefrontal cortex will make a goal-oriented or planned response to that. In a traumatized brain, typically what happens is there's the hippocampus and the prefrontal cortex aren't functioning as well. So it's like sensory information, it's safe or not safe, and response, react. So it takes some time for the brain to heal. But yeah, typically the release of those stress hormones, the cortisol and things like that, also build up over time and can cause a different reaction to safe and unsafe situations. We do see that.
Thank you. A second question that has been asked is, how do you utilize trauma work for individuals with dementia?
So in treating folks with cognitive impairments, depending on the severity of it, if someone has a dementia, you're going to do limited intervention. Typically, sometimes they'll participate in the psychoeducational groups. Handouts are important, writing things down are important, but really their ability to retain that information is not there. And sometimes, when we think about aftercare for these folks, we have to work with the families to let them know maybe this person needs some kind of assisted living, memory care, skilled nursing, and we work with the family to get that set up, because there are times where keeping them in treatment may not be the best thing, or where their resources could go to finding the appropriate level of care for them.
Thank you. Can trauma be inherited to the next generation? And can you provide some tips on how to handle panic or anxiety attacks with an older adult with PTSD?
Yeah. So it's interesting when you hear, we have a family of origin group that we run twice a month on this unit as well. And we often see that, yes, there is a such thing as transgenerational or intergenerational trauma. What it typically is it's a set of maladaptive behaviors that are passed down from parent to child. So for example, you grow up in an alcoholic home, your father's an alcoholic, and then you become the alcoholic parent. and your children become the ACOAs when you were an ACOA. So there's certain, and when I say ACOA, I mean adult child of an alcoholic. So it can really it affect your attachments and beliefs around relationships, as well as your behaviors and your ability to communicate and have intimacy. So when somebody on this unit is having an anxiety or a panic attack, it's important to be present with them in that moment. A lot of times people learn different skills in these groups, but have trouble using them in the time of need. So it's important to reinforce, preventatively, educating people and giving them coping skills that they can use. And then in the moment, supporting them in actually implementing those tools. And sometimes if somebody is very cognitively impaired and we're finding that they're reacting and maybe almost unsafe or just very agitated, sometimes there's appropriate medical intervention that can be implemented. We work very closely with the psychologist and the doctor, and it's really important that as a team we're together on what the best intervention is for that patient.
Excellent, thank you. Another question that is being asked is, where can one obtain the screening, assessment, and diagnostic tools that you've discussed? Also, what was the name of the cognitive scale that you mentioned in your presentation, please?
Okay, so the second part of the question, the cognitive scale, it's called the MOCA, M-O-C-A, and it stands for Montreal Cognitive Assessment. It's just a screening tool. If there is a need for further inquiry, like if we want to get baseline data and percentiles, we'll usually do further neuropsych testing, which we do offer here. There's a mini battery, and then there's a very elongated battery, which is a little bit more detailed and in depth, to look at what's really going on. And that can help us in determining the best setting for somebody post-treatment if they, if we are thinking they maybe do need assisted living or memory care. Can you repeat the first part of that question?
Absolutely. Where can one obtain the screening assessments and diagnostic tools that you discussed?
So where I got these were the Center for Post-Traumatic Stress Disorder. Also, the Department of Veteran Affairs has a lot of good information and screening tools. You can usually get them as a PDF. If you can usually download them for free as a PDF.
Excellent, thank you. Diana, what percentage of people who suffer severe trauma will develop a substance use disorder?
I don't have the exact numbers on that, but what I find is that it's definitely a large percentage of what I see here, just from my experience at Karen with the older adult program, that more than half of our folks have had some kind of trauma history, but I don't know the numbers for you on that.
Okay, excellent, thank you. And what do you say to the patient who says that they don't want to discuss their trauma?
So there's different interventions that we can use. And the other thing we have to consider is that we have to meet the patient where they're at. We have to also assess their readiness to do the work. And if they're in a place where they are not ready, they don't feel that they're ready, or even if they're not willing, we can't force them. It's a voluntary treatment. We can educate them about what we see. So let's say, a patient says, it was a long time ago, I really don't need to do any of that. But let's say their score on the PCL is really high. So maybe just educating them about what we're seeing versus what they're saying, and just educating them on the benefit. But we ultimately have to let them decide.
Okay, excellent. And when working with older adult males who have experienced sexual abuse in early childhood and are reluctant to seek mental health services, what are some of the interventions?
So one of the things that's also important that I didn't mention is the spiritual counseling that can be helpful in that. If you have to look at with we have both men and women who are trained in all of these interventions. And sometimes it's important to ask the person, you have to be sensitive to if they prefer working with a male or a female therapist. But yes, there are there are times where if it's a specific incident where we'll do the PCL, we'll give them the post-traumatic stress disorder checklist. And we've had several of those cases where they've done the cognitive processing therapy intervention, and it has been very successful in decreasing their trauma symptoms.
Okay, and one last question. What about couples that need help? Can Karen bring them in together? A lot of time they have used, drank, enmeshed all of this in together.
Absolutely. We've treated several couples, and they have the option of either having their own room or they can share a room. It just depends on what they prefer. And it's great because we can do family sessions live with them and with their children and with their siblings and with whoever else wants to be involved. But absolutely, because, you know, it's really critical that if one spouse or loved one is getting sober, that the other is getting help as well, because you can't send somebody back into an environment where there's going to be active addiction if they're trying to get sober. It's just a recipe for disaster. But yes, we do treat couples. We've treated several.
Excellent. Thank you again, Diana, so much for your really informative and excellent presentation. And thank you so much to all of our attendees for joining us today. As a reminder, this presentation is eligible for 1 continuing education credit. Watch your email for a link from ce-go.com to complete your evaluation. Before we close out today's session, I'd like to share some upcoming webinar opportunities available from Karen. We'll be offering another presentation eligible for 1 CEU credit on June 30th. Our team at Encore Outpatient Services in Arlington, Virginia, will be presenting on the topic Collaborative Care and Community Partnerships in Mental Health and Addiction Treatment Settings. Registration is now open at www.karen.org/webinars. Also, we'll be hosting a virtual open house at our Karen Ocean Drive program in Florida on Tuesday, July 14th. This will provide a unique opportunity to meet our team, learn about our services, and take a virtual look inside our elegantly appointed treatment facility. You could register for this event at karen.org/virtual-open-house-series. We hope to see you again at one or both of these virtual events. In the meantime, please feel free to reach out to your local regional resource director at any time for additional information, resources in your area, questions regarding admission to Karen about any of our programs. Thank you all so much again for joining us today. Thank you, Diana, and have an awesome afternoon. Thank you, everyone.
Bye.
Bye.